Я с удовольствием представляю следующего докладчика, доктор Cristina Gamez, специалист по ядерной медицине в университете госпиталь Валь-де-Хеброн. И здесь присутствует определенный гороскоп, потому что здесь написано Discover, а в скобках написано Why. Можно понять, что открывая для себя ПЭТ-КТ опыт применения, а можно понять, как Discovery, это линейка ПЭТ-КТ-томографов Джейковская. Please.
Good morning. Thank you, all of you, for being here. And I would like also to thank you because their support and all the experience we got together, and to have the possibility to visit Russia, because I think it's a great country and a great conference. So in a few minutes, let me show you a little bit of our experience. To introduce me, I don't know, I don't speak Russian, so I thought maybe Professor has already done, but I would like to say to you that now I am working in Vall-d'Hebron Hospital. It's the largest hospital in Catalonia, in the north part of Spain, and one of the largest in south of Europe. But this experience I will share with you. I would like to thank my previous service. I was the head of the PET and nuclear medicine department for 17 years, so everything was new constructively, and everything depends on the public health system in Catalonia. So you know that is a kind of opportunity, but also limitations in budgets and high requests about productivity. So first, we had the opportunity to install the first PET-CT in Europe, a hybrid one, in 2003, and it was a Discovery ST for slices. I remember when I was in Milwaukee talking about possibilities, and they have a very nice opportunity to work together. So the first comparison, 2D reconstruction with 3D reconstruction, were performed in Milwaukee with Catalan patients. So I can tell you that we worked a lot. And even at that moment, I had the opportunity to design the facility. I was completely sure that a second machine was needed. So I thought to reserve a space next to it with the same area of control, and we had the opportunity by a public tender to have the second one just a few years ago. And you know, at that moment, no digital PET were available, only Vereos, and they have the problem or delivery at that moment in Cleveland. And we had a very high pressure about productivity. So it was, for us, was a key point to select one stable machine, compatible and very quick. That was our point. So this is the number of the patients we have studied in recent years. As you see, in 2011, we reached more than 9,000 patients studied per year, 60% of them in the new machine because it's quicker, and 40% still in the old machine because it is working very well, and we have many clinical trials ongoing. And you may know that it's very important to maintain the same characteristic acquisition and reconstruction for clinical trials. So we were under high pressure, 2 machines, but 2 different machines. It's like having 2 cars, a small one, old one, and a new one with a lot of possibilities. And so we have to be practical and to decide what indication in every machine. For us, was very determined to reach the 5 rings. If you can afford it, I highly recommend you. Because of the field of view, the field of view from 16 centimeters, we had the opportunity to have to 25 centimeters. As we are doctors, we need also to think about pathology, about the kind of investigation. So it's very important to have everything, for example, the whole lung or the whole thorax for esophageal cancer, also the whole liver in one acquisition. That yesterday we had a little meeting and I explained them that for us was very interesting for us to have delay imaging in hepatic liver metastasis, because in one bed you have everything, and also prostatic cancer. You may know that recurrence can an approach the need bed. At the moment in Spain only choline is approved. So following the protocol of Professor Betesti in Austria, he has one of the best experience in the world. I've just copied the protocol, and for the dynamic study at the beginning, you have a 10 minutes, 1 minute scan, and you may know that the uptake in the prostatic bed or in the prostatic bed or in the lymph node can be indicator of recurrence. So what is important is a larger field of view can include the lymph nodes even in the iliacs, so you don't miss anything important in the pelvis. So all the prostate cancer switch from ST to IQ, and also the advantage to have lower extremities included in the same study for melanoma, sarcoma, myeloma, and also the importance of the sensitivity for the neuroendocrine tumors. And what we are still studying with ST is the brain, because with 16 centimeters the whole brain is included. Also for therapy control with the prior PET scan was performed in the same machine, and ongoing trials. Lymphomas, as we have a lot of pressure, firstly by lung cancer staging, and secondly lymphoma. So when you choose a PET scanner, as you are experts also, it's very important to think about these two groups of patients, in my opinion. So also we have to change about the dose injected and the time for field of view. You know, I'm a nuclear medicine specialist, so I'm always thinking that radiopharmaceutical, you have not only be careful about the symmetry, but also to give the cells the opportunity to have enough availability of radiopharmaceutical. Even you have a very high sensitive machine, you have to be sure that you have enough radiopharmaceutical to be taken on. So we are now more conservative than French users or Italian users, that they reduce 50% of the dose. We only reduce, as you see, 25% of the dose, but we also reduce the time per field view. One thing I copied from the French people in Toulouse is that they use ultra-fast scanning when some conditions of the patients were critical, like sedation or claustrophobia, or instead of taking them under sedation, maybe claustrophobic people, you are with them, just talking, and scanning so quick that it's 1 minute, so you don't need sedation or anymore. So sometimes patient love and quite quick scanning is better than anything else. So you may know that also for us to change completely productivity and scheduling. Scheduling patient is a key point for any vet center. If you want it, in our case we have no cyclotron, we have to buy FDG outside. It's 10 minutes but long, but it's expensive, and the budget for public FDG is limited per year. So you have the same FDG if you do less or you do more. So more patients you do with the same FDG, that means more patients are scanned. Because we are not paid by the system by unit, we are paid in general due of work. So usually when you have to take a decision, it's very important to have a nice schedule. So from 25 patients per day, now 50 patients per day are scanned without waiting list, without Saturdays and Sundays, without nights. So maybe in just the public hospital we can also get a good job, having good things. But one problem I have to explain to the big managers is the staff. Because everybody says, oh, you can work the same thing with less staff. It's not true. You need that, not only double, but you need more staff. Because the machines are so quick. You need somebody to be in the control area, somebody to be helping the patients to go in and to go out from the room, and other nurses taking the history, and other nurses having the checking that everything is correct. So you need a lot of stuff, and not only the price of the machine or the FDG, but I think it's a point to take in count when you have a modern machine that is very quick, if you want to take the more advantages of that. So for CT parameters, we are we have especially a better image quality. Because for the previous protocols, we had already a cutoff from modulated parameters, but the reduction of exposure, what we feel and quantify, was discrete, because we have also performed a big effort before, because now we are very worried about that. In Europe there is a recent law about the symmetry, and we have to take care about that. But a better image was achieved, and for us it's also very important. And the Discovery IQ needs an additional CT for attenuation correction. So for filters we use the standard, the soft, the lung, bone, or others when needed. And for reconstruction, you may know that iterative protocols have a problem. More iteration, more noise. So people, scientific vendors have performed a lot of effort to resolve that problem, and GE proposed a solution that we have also implemented, that is the Q-Clear. And the Q-Clear is like, it's a very complex formula. I am not a physicist, so I cannot explain you. But I can explain what I feel is like a filter to avoid noise and to provide a better delineation of the lesions. So as a clinician, I wanted to check that the Q-Clear was a reconstruction method I can use, because unfortunately or fortunately, I am an old nuclear medicine specialist. I started with PET in 1994 from the 2D without CT, after the 3D, after the PET CT, from 2D, from 3D. So many reconstruction methods have been installed, and we decided to do some scientific work with phantoms and with patients, because we are a big team. So doctor said, maybe Q-Clear doesn't work in clinical practice. Let's check firstly with phantoms, and we published that in Journal Nuclear Medicine. So we have some phantoms, and we reconstructed with the standard reconstruction and with the Q-Clear, and also we check clinical protocols using Cochlear. So, with the phantoms, just seeing the image, what you can see is that the holes are better delineated with the Cochlear. It's one of the conclusions. And also we use NEMA body, and with NEMA we observe that recovery coefficients improve at least 10%. So what was the vendor saying? It was true in our case. So we decided to check at home. And for patients, when we reconstructed the same acquisition scans, we observed that most lesions presented a higher SUV max. So, when we have the comparison, except for 2 lesions, but that we don't know the explanation, honestly, most lesions presented a higher SUV max. So, first conclusion also was that if we decided to change to a clinical use of Cochlear, SUV max were not comparable, and all our reports will be indicated that, and we switch completely. From one day, by consensus, to change to the new protocol, because if not, it can be confusing for our clinicians. And also is when little activity was in the body for any reason, just increasing the beta parameter, that it was not previously available with other reconstruction, we can get so much nicer images as you see. So sometimes that can be useful when you have at 7 o'clock in the afternoon no more activity, and in bed in hospital patient is request, and you can do it. So sometimes it is possible. Finally, to share with you, I think a new machine and mother pet change your life, and some of the practical aspects I've learned is like patient scheduling is like an art, and determines productivity and satisfaction, not only of the patients but also of the staff. Dealing with FDG change also, the total amount and even the individual dose. I have a lot of dreams to be communicated from the dispenser directly to the machines. I don't know why we have so many tools in the future and simple things in the clinical practice we really would like to have. I think this PET-CT in reporting, my recommendation, if you have 2 machines or you have a lot of outside patients coming to your center, is to put the model reconstruction on the model of a scanner in the report in order to even the reconstruction, because can change a lot. And for L accreditation, that you may know is an European accreditation that guarantees quality, what we observed at the beginning is that the Cochlear was too much good. So we have at the beginning to worsen the images in order to send to Vienna to get the accreditation. Now this kind of problem is already solved. So sometimes clinical and practical life goes faster than scientific points. So it is solved, and they are looking for more solutions to give to the clinical for mother pets. And finally, let me see that mother pets are more complicated. They have a lot of advantages, but we have a great work to do together with the vendors, with the industry, because probably we need a changing of the parameters. We have to think about other parameters to establish quality imaging. And in my opinion, I would like to participate in any project with radiomics. I think the textures or the parameters are so nice, but we don't know. And if it is possible, I know it's like a dream, but clinicians, we have a lot of work to do. So I would like to have more automatically methods that directly give us the information. Because if we have to invest a lot of time, we reduce our time about interpretation and about caring about patients. So thank you very much for your attention. It's a great pleasure. This afternoon we will also share with you a session about therapy and pets. And please, if you can, you will be welcome. Thank you.